electrolytes, we're going to go through, I'm going to lecture and teach you some things. And then I brought some worksheets for you all to kind of pair up or group up in twos or threes or whatever and see if you can answer them. And then I will go through and make sure that everybody's straight, if that makes sense. So what we're going to be talking about is we're going to be talking about getting paid, how to determine what kind of IV fluids a patient needs, how to know if they're getting better, if they're getting the right fluid, and that kind of thing. So we're going to start. Does that pick up a little bit? So we're going to talk about the spaces. So it's going to be real important that y'all understand the spaces that fluid can get into and that they do get into in your body. So we're going to define them. The first one's the intracellular space. Can y'all see that? Is that light glaring on there too much? It's glaring a little bit. I think 4 is the best setup for. There we go. So the intracellular space, y'all, that's really easy to figure out. It's the space that's inside your cell, right? Remember? It's inside the cell. So we have fluid in every cell that we have. There's fluid inside the cells that are within our bloodstream, and there's fluid in my knee cells and my eyeball cells. Everywhere there's fluid. And then there's the extracellular space. And so when you think of the difference in intracellular and extracellular, you think, okay, well, that means it's outside the cell. And it is. But typically when we talk about extracellular space in healthcare, we're talking about the volume part of what's in your blood space. So not the cells, but the liquid part of your blood, the plasma part of your blood. That part that we talked about that looks like urine or light yellow if you let the red blood cells fall down. And then the intracellular space is the space that's in between the cells, but not inside the blood vessels. Does that make sense? So when you get a bug bite and it starts to swell up, that fluid that's outside the cells there, that's your interstitial space. So we have the fluid inside the cells, we have the fluid outside the cells but contained in the blood vessel space, and then basically all the other fluid that's in your body is in the interstitial space. Does that make sense? Am I following along? Because we're going to talk about these fluids and how they make fluid move from the cellular to the interstitial to the vascular space. And then there's another thing down there called a third space. And a third space, what a third space is it's an interstitial space, but it's like enough fluid that you can pull fluid out. Y'all all know what water on the knee is? Y'all have all heard that, maybe you get an injury and you go, and they get a syringe and they'll pull the fluid off your knee. That's an example of a third space. So it's not intracellular or extracellular, it's interstitial, but it's a whole bunch of it like there. You can really kind of just pull it out. Does that make sense? Third space in it, you're sending fluid into an interstitial space, a large volume of fluid. Okay. The next thing that we're going to talk about is pressures. So the first pressure we're going to talk about is hydrostatic pressure. Let's see, somebody got a water bottle? I'll pick up your cup right here. So if we pretend this coffee is water, the pressure that this liquid is putting against its container is hydrostatic pressure. Does that make sense? It's the pressure that's created by water. So if I were to take a knife or a pin and poke holes in this down here, where would this fluid go? Out. So that's really important to know. Hydrostatic pressure has a pushing force that tries to push water out of its container. Thank you. Thank you. So the water in your blood vessel space is always trying to get out. I mean, water just tries to get out of where it is. So it is a pushing force. Anything that will increase the hydrostatic pressure will increase the rate at which fluid goes outside of your vascular space. Do y'all remember where it's going to go out from? From the inflammatory lecture? It's that capillary space. So the water that's in our blood, the non-cells that are in our blood, as it travels down through the artery, the capillary space, and back into the veins, when it gets down here into the capillary space, that's what's pushing that fluid out that we talked about last time, is that hydrostatic pressure. Okay? Colloidal pressure or oncotic pressure, those two words mean the same thing, and that's the pressure that's created by protein. So a few things to know about protein is that sodium follows protein, and then water follows sodium. So anywhere that you increase the amount of protein in your body, you're going to increase the movement of water towards that protein. Does that make sense? For example, when patients have big burn injuries and they lose all this fluid from the injury, once that capillary leak, that capillary permeability goes back to being normal, we start giving them albumin to pull the fluid back into their blood vessel space. But the other thing that's important to know about protein is that it's a very large molecule. And so unless you have an inflammatory response going on, it's not going to go through that capillary membrane. So again, if you think about this blood running through artery, capillary space, vein, so I've got protein in here, I've got water in here, and I've got sodium and all kinds of things. So it comes down here, the water's trying to push out, right? So when it gets here, the water's pushing out. But because the protein doesn't push out, the water gets sucked back in. Does that make sense? So you have to have adequate hydrostatic pressure to get fluid out to your tissues, and you have to have adequate protein in your vascular space to pull it back in. If we are in a normal state of fluid balance and we don't have an inflammatory process going on, that's how our fluids move around. And then do y'all remember what diffusion is? What's diffusion? The movement of water or particles? Particles. From high concentration to low concentration. Diffusion is what happens, do y'all remember with the sodium and potassium pump? Because you remember, we're going to talk about this again, we're talking about fluids today, electrolytes, but potassium is mostly inside the cell. And so sodium will diffuse in there because the sodium is higher outside the cell and the potassium is higher inside the cell. So they diffuse across that membrane, and it takes that pump to pump them back against the gradient for diffusion and osmosis. So the take-home messages are, hydrostatic pressure pushes water out of your vascular space. Anything that will increase the volume of water in your vascular space is going to make you do what? If you're pushing a lot of fluid out of your vascular space, what are you going to do? It's going to slow up. Your interstitial space will fill up first, and then your cellular space will fill up. And then the opposite is true if I go and I put protein, anything that increases the protein in your vascular space is going to suck water out of the interstitial space and out of the cellular space into the vascular space. Your cells, they're great buffers. They try to make everything perfect in our body, and they're going to try and make things perfect in the vascular space. So the cells in the interstitial space, they will give up their stuff to their own detriment until they die to try and make things correct in the vascular space. All right. So we're going to talk about different fluid types. There's only 3 types, so we don't need to spend really any time on this PowerPoint because that's what the next 3 are. So isotonic fluids, what that means is that the concentration of particles in that fluid is the same as it is in human blood. And the one that has the biggest player in fluid balance is sodium. So that's really the electrolyte that we're worried about. So if any of us were to have a sample of blood drawn and the lab was gonna measure the concentration of sodium in our blood, in any human being's blood, unless you're dehydrated or something, it's gonna be 0.9% of your blood volume is sodium. 0.9% of the liquid in your blood is sodium. So 0.9% sodium is an isotonic fluid. Now, and Ringer's lactate is another one. Those are the only two we're going to talk about. Ringer's lactate also has sodium in it, and the only real difference between normal saline and Ringer's lactate is that Ringer's lactate also has a buffer in it. Lactate, it's a buffer. So we use lactated Ringers when patients have big stressors, you know, great big surgeries. They've been in a car accident. They've got a massive capillary leak. They're burn patients. They get Ringer's lactate. So that's the only real difference. It helps buffer. So if I put into my bloodstream some normal saline, so again, I got this blood running through here, and the fluid that's coming through my bloodstream has 0.9% sodium in it. If I put 0.9% sodium in that space, is it going to push or pull fluid? It's not, because it's the same concentration. Right? I'm not putting in a higher concentration of sodium or protein, and I am not putting in a higher concentration of water. So normal saline stays in the vascular space in a person who is fluid balanced. We're going to talk about fluid imbalances coming up, but in you and me, that's the way it works. That's why we stay hydrated and our cells get, you know, everything exchanged that they need. So you're going to need to know the properties of the fluid, what they do. So this won't change the size of the interstitial space. It won't change the size of the cellular space, and it should stay in the vascular space. Now, if we have a fluid imbalance, it's going to move, and we'll talk about that coming up. I guess that's enough said about that. And you're going to need to know, you know, where these isotonic fluids, what they do, where do they make water move to, and you're going to need to know what the names of those are. So luckily with isotonics, there's only two. There's normal saline and Ringer's lactate. Ringer's, sometimes it's called Ringer's lactate, sometimes it's called lactated Ringer's. You'll see it abbreviated a lot of times as RL or LR.
You said sodium. Is saline the same thing?
Yes.
Okay.
Thank you. Saline is sodium. So then hypotonic fluids, you can see there's a longer list. And a hypotonic fluid has more water in it than it has particles, and in particular sodium. So if I put a liquid into my vascular space that has more water in it, what do we say that's going to increase? The hydrostatic pressure. Right? Because I'm putting a higher concentration of water into the vascular space. So if I put more water into that vascular space, where's that water going to want to go? Out. So the first place it's going to go is into the interstitial space, and then it's going to move into the cellular space. So it will make you swell up. It'll make cells swell up. You know, keep in mind that a cell can only swell so much before it busts open and dies. Let's see what else we have up there. So it will cause edema. These are all the different types of hypotonic fluids. So if you know hopefully what you notice about that is they all have a lower concentration of sodium, basically, than 0.9%. When you see the ones down here that say D5.9% normal saline, so what that means is if you took a 1,000 milliliter bag, when they mix that, they put 500 milliliters of D5W in it and 500 milliliters of normal saline. So you've cut the concentration in half, basically. Does that make sense? So D5.9% saline has the same saline concentration of that 0.45 up there. And you don't have to remember that part, but just know that if you see a fluid type with D5W mixed in it, you got to cut that number in half. So anything that has D5W in it really is going to be hypotonic. Now there's a little note down here about a disclaimer about D5W, and so we want you to think of D5W as a hypotonic fluid, because when we start talking about who gets what kind of fluid, it's going to be important to know that when D5W goes into your body, it works like a hypotonic fluid. There's no sodium in D5W. But back in the manufacturing plants where they process this stuff, they may mark the bag as being isotonic because it has the same amount of glucose, the same amount of dextrose that we have in our body. So, you know, in a clinical lab, yeah, it's isotonic. But as soon as we put D5W into a person's body, their cells are going to use the glucose, the dextrose up really, really quickly. And so then you're basically going to be left with just water. Does that make sense? So for this class and for all of your classes, you need to think D5W is really hypotonic. So if you are, you know, you're getting ready to take your exit exams from here and all that kind of thing, and you see a table that says it's isotonic, don't get all upset and think, oh no, they taught us wrong. It's just that particular textbook may call it hypotonic. If it's got water in it, you know, it's hypotonic. And then we can also certainly, I mean, you all have been dehydrated at some point. You can drink a bunch of water and you can rehydrate yourself. So if a patient comes to the hospital and they are dehydrated and we need to get them hydrated, if they can drink water, they can drink water, right? And that would be better than sticking a needle into a vein and then having a, you know, chance of all the complications that can happen with putting a needle in somebody's arm. So hypotonics, they're going to leave the vascular space. So think about this. If somebody is shot and they're bleeding, do you think it's a good idea to put hypotonic fluid in them? Oh, it's just going to bleed, so it's not going to help them. It's not going to keep fluid in. Does that make sense? Okay. All right. And then the next thing we have is hypertonic fluids. And so hypertonics then are going to be the opposite of hypotonics, meaning that they have more sodium or more sodium or more pulling power than your blood does. So those examples are 3% and 5% normal saline. Then we also use albumin. And y'all, albumin is a protein solution. So remember we said where albumin goes, salt follows, and then water, well, sodium follows, and then water follows. So albumin, when you're talking about fluids, is going to act as a hypertonic fluid. And then mannitol is the other one that you see up there, and that's really a diuretic. It's called an osmotic diuretic. And what it does is it pulls fluid out of cells into the vascular space, particularly your brain. So you'll see that when you go to clinical, anybody who has a head injury or they have maybe a brain tumor, you may see them getting infusions of mannitol. So we listed up there even though it's a drug because it has such a pulling force. So I kind of have been not alluding, but I've just been saying it. So hypertonic fluids are going to pull fluid into the vascular space. And if they pull fluid into the vascular space, where are they going to pull it from? The intercellular space and the interstitial space. So if you give a hypertonic fluid to somebody, you're going to move fluid into their vascular space at the expense of their interstitial space and their cellular space. So this is going to make the cells, shrink and get stuck. Something that I didn't mention with the hypotonic, I thought it popped into my head until just now. So in that fluid that's in our interstitial spaces, that is where everything that goes into our body has to go through to get to our cells. So if you take, you take a multiple vitamin in the morning and you're dehydrated, that multiple vitamin is going to be sitting there in your interstitial space because it's sticky, there's not much fluid there for the stuff to move. Does that make sense? If you're volume overloaded, if you're having a swelling process, it's the medicine that you give is going to get pushed out into the interstitial fluid and it's just going to sit there. So we typically will avoid giving patients like subcutaneous and intramuscular injections if they're really volume overloaded or dehydrated because it's going to make it harder for things to change places. And that's true for oxygen too, right? I mean, if I don't have much blood for the oxygen, much fluid in my blood for the oxygen to move through, I'm going to be, my oxygen levels are going to be low. so let's talk about the different fluid states. We're gonna talk about being dehydrated or having fluid overload. And those lists of words there are just synonyms. So what do you think hemoconcentrated means? How do you think you would know if a person was hemoconcentrated? Mhm. There's a lot of protein, but, so y'all, you already know what a normal hemoglobin and hematocrit is, right? You know what a normal white blood cell count is. So if somebody has an elevated, we're talking about dehydrated, an elevated hemoglobin or an elevated hematocrit, it could be that they're dehydrated, right? It could be. You're gonna learn what normal sodium values are, what normal potassium values are. They're probably gonna be elevated, right? If you don't have a lot of liquid, that sample of blood that you pull is gonna have more stuff in it, so that's what hemoconcentrated means. Your lab values are gonna be elevated because you're lacking water in your vascular space. And then hemodiluted is the opposite. There's so much water in your vascular space that your numbers are artificially low. I think we talked about that. We talked about that with polycythemia, if you remember, when we talked about blood having tertiary polycythemia because of your fluid imbalances. That's what's going on there. So people will also say they have low volume, they have decreased vascular space when people are dehydrated. When people are overloaded, you'll hear them say they're wet, they have all overload. Those are the big ones that you hear are hemodiluted.
Question, so that's the increase in the vascular space? You said the hemoglobin?
Yes, there's increased fluid in the vascular space, increased water. So that'll make all of your lab counts become low. Certainly not high, they might be normal to low. Okay. So, causes of dehydration. So what you're gonna see, so we're gonna, on the test, we're gonna ask you lots of questions about, well, you know, what happens if a person gets a hypotonic fluid or a hypertonic fluid? You know, because we wanna make sure that you know where the fluids are moving, you know, what's gonna happen to their cellular space, their vascular space, or whatever. And then we're gonna also give you some questions where we describe to you what the patient, their signs and symptoms. From that, you have to figure out what's wrong with them and what kind of fluids they need. And then how do we know if the fluids we're giving them are working? And how do we know when we need to stop? Does that make sense? So that's what I brought on these worksheets. We're gonna try it a little bit different. Usually I draw a lot of pictures, but we're gonna try these worksheets this time and see how that works. So y'all know how you get dehydrated, right? You're vomiting a lot, you've been outside running and it's hot, you haven't had anything to drink. You could have, maybe some patients take diuretics and they don't drink enough to stay hydrated. Vomiting, diarrhea. If you have a fever, you might get dehydrated. If you don't feel well, you may get dehydrated. And then people who have diabetes get dehydrated. We're gonna spend a whole lot of time talking about that whenever we do the endocrine lecture. Okay, so signs and symptoms. It's gonna be so important for y'all to be able to distinguish between dehydration and volume overload. And then I'll tell you when we get to talking about the sodium, but hyponatremia, the signs and symptoms are pretty well gonna match up with the hypernatremia is gonna pretty much line up with dehydration. But we'll talk about that when we get there. So, urine output's gonna be low. Why do you think the urine output's low if you're dehydrated?
Because you're not taking in fluids.
Yeah, but let's get a little more specific. Let's go drill down a little bit more. If you're not taking in enough fluids are not getting to what? Your kidneys, right? So that 30 milliliters an hour number up there for urine output is it's one of those numbers that you just have to memorize forever. 30 milliliters of urine an hour in an average adult means that there's enough blood getting to the kidneys that they're adequately perfused. So whenever you have patients whose urine output's less than 30, your first thought until you prove otherwise is they don't have enough blood volume. Now, if they also have renal failure, then, you know, all bets are off. But if it's a person who doesn't have renal failure and they don't have enough urine output, they are not getting enough blood in their kidney. So that one's super important. What else do you think might be true about their urine if it's if there's not a lot of blood getting to the kidney to make a lot of urine? It's dark, might have like, we call it trash, you might see particles and cells and stuff in there. What do you think it would make for specific gravity? Do I have that up there? What do y'all remember about specific gravity?
Make it high.
It'll make it high. Do y'all remember what a normal specific gravity is? Somebody in here has to. It's like 1.004 to 1.020, I think. So if the kidneys aren't being perfused, they're not gonna clear things out, the urine's gonna be really concentrated. Y'all know what skin turgor, have y'all done that in health assessment yet? Yeah? Where do you check a person's skin turgor? Yeah. Maybe over their breastbone, maybe the forehead. You kinda wanna stay away from hands and old people because old people just have dry skin and less tissue, less fluid anyway. So you might wanna pull somebody, try to pull their hips up on their chest or their clavicle and check that out. Weight loss. So, I went, the other night, today's Thursday, so that's what I was gonna say, Sunday night, I had a very healthy lunch of queso and tortillas, super healthy. And so then the next day, we ended up going to a Mexican restaurant, and guess what I had again? Chips and queso, and this wonderful salad, the chicken was so salty I could hardly eat it. So when I got up the next day, I weighed 3 pounds more. From the sodium. So, that is, so I have access to a diuretic. I thought, I don't wanna weigh 3 pounds more than I did yesterday, so I took my little diuretic, and at the end of the day, I was back down 3 pounds. So fluid is very directly related to your weight. 1 liter of fluid weighs 2.2 pounds. So, in gaining my 3 pounds, I had retained 1.5 liters of fluid. Now, it would have gone away in a day or two, but I was impatient. I don't recommend you do that. Okay, so 1 liter of fluid weighs 2.2 pounds. Tachycardia. Y'all see how I got a star up there, my tachycardia? So, when somebody's heart rate goes up, unless you know that they have something else going on, again, your first thought is they don't have enough volume. Whenever we don't have enough volume, whenever your organs aren't being perfused, they're not. So if we don't have enough volume, oxygen can't change places. And your brain senses that, right? And your brain can also sense your blood pressure. So what happens is your brain says, okay, heart, speed up. If you beat faster, you're going to send more blood out to this person's organs. So that is the first sign, y'all, of low volume. So it can be dehydration, low volume, or it can just be low volume again because somebody's bleeding. And y'all, on these exams, if we tell you the patient's heart rate's 110, we're not telling you that because it's not important. You know what I mean? Typically, we don't give you a whole lot of fluff that you don't need. So always, 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 always address an abnormal vital sign. If you're given an abnormal vital sign on a test, it's not there as a distractor, right? That is the most basic thing that we need to be able to recognize. And clearly, if you have an abnormal vital sign in your patient, you need to address that as intently as you would address it on your test. Low blood pressure, which is hypertension. You know what your normal blood pressure is? Have y'all done that yet?
120 over 80.
Yeah, it's less. 120 over 80 now. A lot of you in this room, especially if you're athletic, you might have a blood pressure of 90 over 50 or something like that. And it's good if you do. So we're not going to tell you that the person has low blood pressure on a test, though, unless we want you to know that it's low. Or if we did, we'd say, they're an athlete or, their heart rate's fine. But a lower than 120 over 80 blood pressure and an elevated heart rate, again, goes straight to, oh my goodness, they don't have enough blood volume. Because you can die from not having enough blood volume pretty quickly. If they have heart disease and you don't know it, that's not gonna kill them in the next 30 minutes, right? But if they've bled out or for whatever reason, their blood volume's low, that can cause problems very quickly. Thirst. Thirst is probably the first indicator. Like as you all feel a little bit thirsty and you're sipping from your drink, that means that your volume's getting a little on the low side. And we've already said dark urine. Something else that's, signed, sunken eyeballs, did y'all learn that in health assessment yet? So, you know, if the tissues behind your eyes and in your face don't have, much fluid, things are gonna, the tissue's gonna collapse around your face and in your eyes, under your eyes and that kind of thing. And then there's fluid volume overload, which means you have too much fluid. Hey, backing up to dehydration, what do you think the lab values would be in dehydration? Elevated or low? Elevated, yeah. So here, they're gonna have low electrolyte levels, low hemoglobin, low hematocrit, that kind of thing. Overload can happen, it's hard for somebody to drink enough water, to get overloaded. I mean, it's possible if you drank several gallons of water a day, you could. But typically, I shouldn't say normal, but healthy individuals who don't have any kind of heart failure, liver failure, kidney failure, they don't typically get volume overload. So usually if they have volume overload, it's because maybe they've come into the hospital and they were real dehydrated and we gave them too much fluid. Or maybe their heart doesn't work so well and they couldn't really handle those hypotonic fluids. Does that make sense? Okay, so for overload, we're either gonna give you some crazy story about, somebody who drank a swimming pool full of water, or they're probably gonna have some kind of disease, heart, kidneys, or liver disease to get overloaded. So the signs and symptoms, the one that's got the star up there is crackles. Yes, so crackles, if you take your hair and you rub it together by your ear, when you listen in a stethoscope, that's what a crackle sounds like. And what that is, what causes those crackles is that there's fluid sitting down in the base of your lungs, and when the alveoli open up, it makes that little noise. It makes me think about Snap, Crackle, Pop, Rice Krispies. When you put those Rice Krispies in the water, it kind of makes it, that's kind of what a crackle sounds like. Y'all know what Snap, Crackle, Pop is? I didn't know if that was such an old, I didn't know if that was such an old commercial that y'all wouldn't even know what Rice Krispies were. Huh?
We're just old, it's fine.
There you go, just old like me, old as dirt. So that is, anytime a person has crackles, y'all, they are in fluid volume overload. There is no ifs, ands, or buts about it. Well, I guess they could have pneumonia, but they have fluid in their lungs if they have crackles.
Is ascites an example of this?
Ascites is in your
liver?
belly.
Yeah.
Mm-hmm. And ascites happens mostly in liver failure, because if you have liver failure, you don't make protein, so you can't keep that in.
Yeah.
What did you say about the alveoli?
It's when you're breathing in air, the alveoli let the air out, and when they release the air back out to go out in the lungs, and it's sitting in water, it makes that crackling sound. Full bounding pulse. I don't think I had thready pulse on the dehydration, but did I have thready pulse on the other one?
Yes.
Okay.
Yes.
We didn't talk about what thready pulse meant, did we? So when you're feeling the pulse, you can all feel yours if you want, but you should feel like a distinct bump, 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 bump. If it's thready, it means there's not much volume in there and it's hard to distinguish where one beat starts and the other one stops. You think about, you see somebody taking a jump rope and doing like this, and it kind of makes like a snake, a little, like you can't really, it's like it never really completely stops. So that's a sign for dehydration. Full bounding pulse is like, it's like your blood vessels are probably sticking up, and you can feel the pulse really good and strong. People will probably tell you they can hear their heart rate pounding in their ears too. Weight gain. So yeah, I ate all that salt and I gained 3 pounds. Bulging eyeballs, again, if these tissues all, if it's swelling anywhere, so if the tissue behind your eyes shrinks away or swells up, it's gonna move your eyeballs, make them look like they're poking out or sunken in. And dyspnea is shortness of breath. Jugular vein distension, y'all probably haven't learned that yet in health assessment, but so like while we're all sitting up here, you shouldn't be able to look at the person sitting next to you and be able to see their jugular veins. They ought to be flat if you're upright. But if somebody's, they're propped up a little bit and their jugular veins are distended, you can see them. then there's too much fluid on board. There's too much volume in those jugular veins. Okay. What time is it?
9:37.
Okay, good. Here's a little important tidbit about fluid, and then we're gonna talk a little bit about electrolytes, and then we're gonna work through these cases. So I'm hoping that, we'll finish this part, then give something like maybe 40 minutes, 45 minutes or so to work through those cases, and then y'all can get out in time to go get something to eat or, unwind a little bit before that nursing process section. So, insulin and potassium, y'all, they enter a cell together. Just store that away in your memory. We'll talk about it again when we talk about diabetes. Daily weights is the best indicator of a person's fluid balance. And it should be daily weights, same time, same activities, same scale, same amount of clothes. Typically, it's best to have the patient get up, go to the bathroom, take off your clothes and get on the scale. Their volume, their vascular volume. Like I told you, I weighed 3 pounds after I spent 2 days eating salt and chips. So, I do that every morning when I get up. I just go step on the scale. Probably that's pathological, but I do it. But if you have heart failure or liver failure or something like that, you should be doing it. Diabetes insipidus. There's a hormone called antidiuretic hormone. And antidiuretic hormone makes you hold on to fluid. So if you have excess antidiuretic hormone, we're going to talk a lot about this when we do the endocrine stuff, you're going to retain fluid. If you have inappropriate antidiuretic hormone, inappropriate antidiuretic hormone, you're going to, if you have diabetes insipidus, you're going to pee a lot. You don't have enough antidiuretic. If you have SIADH, inappropriate antidiuretic hormone, you have too much. That is the one thing that I always have to stop and think real hard about. So antidiuretic hormone makes you not diurese, not pee. So if you don't have enough of it, you're gonna pee a lot. If you have too much of it, you're not gonna pee. It's gonna make you hold on to your urine. And then it's also important to know that folks who are obese have a lower total body percentage of fluid than non-obese people. So they also become dehydrated more easily. And the same is true of the very old and the very young. They also become dehydrated or volume overloaded much more easily.
Can you explain that to me?
About
The obese.
So it's people who are obese, they have a lower percentage of body water. When you think about the contents of your body, if you have excess fat, there's no extra fluid, right? Fat is not perfused very well, and so you've got all this tissue there with no ability to bring fluid in and out, so it makes the person more susceptible to becoming dehydrated.
So does that mean water instead of weight then?
Yeah, I was confused about that.
Have a lower percentage, they have lower percentage of total body water
Okay,
and
so-
weight, or weight. Well, no, percentage of total body, yeah, water, that should be water. I need to change that on that slide. I don't think I can change it while it's in slideshow. That's funny, nobody's ever said that before. Okay, also super important to know that you should take in 1.5 to 3 liters of fluid a day, every day. That's a lot of fluid. If you do that, you're gonna be going to the bathroom every hour and a half or every 2 hours, but you really should be. When you go to the bathroom and you pee, if you can see yellow in the toilet, you don't have enough fluid. Like your urine should be just as clear as the water, well, if you're peeing in a toilet, it should be just as clear as the water. You really shouldn't see it at all. So when you see really dark urine in a person, they are dehydrated. They may not feel it yet, but they don't have enough fluid. We already talked about the weight thing, and we've already talked about that weight, that urine output, that hourly urine output. So 30 milliliters an hour is what's expected of an adult. And then if you're smaller, if you're 50, 60, 70 pounds, it should be 0.5 milliliter per kilogram of body weight. You're gonna find when you start working in the hospital sometimes, a lot of times, there'll be parameters written in the chart. The care provider will say, notify me for this, that, and the other. They don't always put this in there because that's just the gold standard. They expect that everybody knows that. So it should be greater than 0.5 milliliters per kilogram if you're not an adult. And typically an adult is about a 60 kilogram person or better. And that is called obligatory urine output. And again, what does that mean? It just means that your kidneys are adequately perfused. And then, you couldn't have adequately perfused kidneys and not an adequately perfused lung unless there was some kind of trauma. Does that make sense? So that's the indicator for how well a person, how much blood a person's getting through their kidneys. So we talked about fluids, and we're going to talk about electrolytes a little bit. Okay. The first, we're just going to talk about sodium and potassium this semester. We were trying to limit that so that there's not so many for you to memorize. Sodium and potassium, they're probably going to be the two electrolytes that you remember the most about all the time anyway, because sodium is such a big player in your fluid volume, and then potassium is so critical to the heart that like you probably will never forget what those normal values are, and you're always going to remember the signs and symptoms because it's going to enter your everyday life while you're working. The others you're probably going to have to memorize every time you take a test, right? And then depending on what kind of unit you go to work in, if those procedures, like if you work in a delivery room and maternal care, magnesium is super important. So those nurses who work in labor and maternal care can tell you right off the top of their head real quick what a mag level should be. I kind of do know because I've been teaching it for years, but until I started teaching I didn't know what it was. I would just be able to have to look at the report and see if it was normal or not. But potassium and sodium, you'll never forget. So sodium, like we said, it is a major player for fluid balance. It is extracellular, so it lives in the vascular space. When you start studying these electrolytes, see what the normal value is right here, how that's a big number. So those that have high numbers typically are extracellular, and the ones that have lower numbers are intracellular. So you're going to see like a potassium value is 3. It's low. So that might help you. I don't know that we'll ever ask you if something's intracellular or extracellular, but it may have been helpful in chemistry, I don't know. And we already said that wherever sodium goes, the water's going to follow, and the sodium is going to follow the protein. Potassium and sodium move in opposite directions. Why? But you already know that because of the sodium-potassium. So sodium is usually reabsorbed by the kidneys, the tubules in the kidneys, and it has a big impact on your nervous system. So patients who have abnormalities in their sodium levels are going to probably have some neurological signs and symptoms. Angiotensin II, you'll learn about in kidneys and renin and angiotensin II, but if your kidneys are not being perfused very well, if your kidneys release this thing called renin and it ends up being turned into angiotensin II, which makes your blood pressure go up. So I guess it's a checks and balance or something to help balance out your fluid balance. And then we do lose some amounts of salt through our skin. But you know that, right? Like if you're running and you wipe your face off and you happen to hit your mouth, you can taste the salt that comes out of your skin. And then we already talked about antidiuretic hormone when we were talking about fluids. So we're going to talk about high sodium and low, we'll still talk about, we'll continue talking about this before we start talking about the signs and symptoms. Most of this we've already said. You're going to see it looks very much like we said about dehydration and volume overload. So if your sodium level creeps up, you're going to be thirsty. If it's down, you're going to be swollen. Creeps up, you're going to be dehydrated. You have signs and symptoms of dehydration. If it's low, you're going to have signs and symptoms of low volume. Okay, we've kind of talked about those already. I don't think you need to study too much about angiotensin just yet. Dr. Swansey's going to ask you a lot of questions about angiotensin on the renal exam, and once she does the kidney lecture. These are ways that you can lose fluid, the ways that you can become dehydrated, the ways that you can become hypernatremic. They all look the same. that make sense? So we didn't, well, I did say if you went out and ran, you might get dehydrated, you didn't have anything to drink. So, anything that makes you lose a lot of fluid can, make you, your sodium go up. I don't think I had sweating on the dehydration slide, but if for some reason you are profusely sweating and not taking in fluids, you'll get dehydrated. But surely that, y'all know that, right? Because if you're outside and you're doing a lot of exercise, you know, you take your water bottles with you.
So hypernatremia and dehydration are like the same?
Yes. And then hypo and overload over years. You can have you can have hypernatremia or hyponatremia if you have some other disease states, but by and large, you see hypernatremia usually dehydration. Concentrated tube feedings. People who get long-term tube feedings typically are patients who, you know, some are in the hospital, some have, you know, big head injuries and that kind of stuff, and they're not able to eat, and so they'll get tube feedings for the rest of their life. Same thing like in nursing homes, and so every now and again, water has to be added to these patients. Otherwise, if the tube feeding is too concentrated, they don't get fluid, it can dehydrate them. So look at this. When you see those signs and symptoms, don't they look to you like dehydration? The only ones that we didn't really talk about down there are these down here, central nervous system signs and symptoms. So people, when their sodium gets out of balance, they start acting goofy. You know, maybe have slurred speech, maybe they're confused, a little disoriented, maybe a little agitated. So it's likely that on the exams we'll say, we're going to give you some signs and symptoms and ask you which electrolyte imbalance do you think your patient has. So if we're giving you neurological signs and symptoms, well, you can go ahead and rule out potassium. Just go ahead and mark those two off, and then you just have to decide, is it hyper or hyponatremia? And then you're going to have to default to the other signs and symptoms. You know, do they line up with hemoconcentration or hemodilution? Does that make sense? Because when we start talking about hypotension, you're going to see the same thing with headaches, confusion. That's what HA stands for, is headache, by the way. That was an abbreviation I made up for myself when I was in nursing school, and I still use it. So any kind of alteration in your neurological system, then you need to go straight, your brain needs to think sodium. And then causes of hyponatremia, there are some hormonal imbalances that can cause it. And then the same things that we talked about that can cause volume overload. Failure, different diseases, heart failure, kidney failure, liver failure. Addison's disease is a hormonal disorder that we'll talk about when we do endocrine. We've already talked about too much antidiuretic hormone. Aldosterone you'll learn about again in the kidney, so I wouldn't worry. I wouldn't try to commit aldosterone to memory just yet. You'll learn that very well in the renal lecture. And so the signs and symptoms, look, they look the same thing as what we said for volume overload. Except, again, you get down here to these central nervous system things. And then you can't, I wouldn't try to memorize, oh, well, on the hypernatremia, lethargy wasn't on there maybe. I don't remember if it was or not. But anything neurological, you just have to think sodium. Then you have to, again, go back to these other things that indicate, do they have too much sodium or not enough? You do need to go ahead and memorize that sodium value that I had up on slide 135 to 144. Potassium. Potassium is an intracellular ion. I don't have on this page up here, but the thing that you should think about with potassium is muscle movement and muscle activity. And muscle activity, what's the most important muscle in your body? The heart. So the impacts of potassium on your heart are huge. So it's also controlled by your kidneys. Anything that increases your urine output will decrease your potassium. You'll see when you go to the hospital next semester that patients who take diuretics every day for their blood pressure probably are also getting a potassium supplement. Because anything that's going to increase your urine output will make your potassium change. we already said it's mostly in the muscles, it is excreted by the kidneys. You lose some in your stool and sweat, but the vast majority is gonna come out of your kidneys. And then we already said on the other slide that it moves in the opposite direction of sodium. So y'all feeling good about potassium?
You said increase urine output, they'll have, is it low or high potassium?
They'll have low because you pee off potassium, so if you pee more, you're gonna pee out more potassium. So again, I think you can just know that if you increase your urine output, that you're gonna lose potassium. But I do wanna talk about these intracellular shifts in ions, okay? So, hydrogen ions and potassium ions move in opposite directions. So do y'all remember what state you're in if you have acidosis? Do you have too much or too little hydrogen? Too much hydrogen in your bloodstream. So if you have a lot of hydrogen in your bloodstream, remember back earlier today we said your cells are really good buffers, and they try to fix the vascular space for whatever's wrong. So these cells, your cells are gonna take on some of that hydrogen, let some of that hydrogen come out of the vascular space, and they're gonna, try and lock it away in the cell so it doesn't hurt, so it doesn't imbalance the vascular space. But when hydrogen moves in, potassium moves out. So in a state of acidosis where you have a lot of hydrogen ions in your bloodstream, it's moving over into the cells, and the cells are spitting out potassium, which goes back to the bloodstream. So you need to remember forever that if you're in a state of acidosis, you're probably gonna have a high potassium level.
So high hydrogen equals high potassium? So it says,
Yes,
right? Okay.
yes. So,
Like high potassium in the blood or in the cells?
in the blood. So your potassium typically lives in the cell. That's why when you, the values, the normal values are so low. And so if your hydrogen ions are increased, your cells are gonna try and absorb some of that hydrogen. But think about those cells as only having a limited amount of space. So when the cell takes in hydrogen, it's gonna spit potassium out. It's gonna first go to the interstitial space, but it's gonna make its way back into the vascular space. So when a person, and y'all are gonna do acid-base balance, I think 2 weeks from now. So Dr. Swansea will talk a lot about that again in the acid-base lecture. But if you have acidosis, you should expect that a person would have an elevated potassium level. And the same is true if they have alkalosis, they should have a low potassium value. And then we've already said a half dozen times that sodium and potassium, they push each other in opposite direction. Well, the sodium pumps it in other directions. And we also said that insulin and potassium move into the cell together. So what can cause us to have hypokalemia? Anything that makes us lose it, mostly you lose it from your gut. So if you have vomiting, if you have our patients that have NG tubes sucking it out of their stomach, sucking their stomach contents out, can get hypokalemia. Patients who have big fluid leaks can lose it. If you have too much insulin for any reason, since insulin will move potassium into a cell. Burn patients are going to lose potassium because of that humongous capillary leak that they have and all the cell death that happens, and it gets washed out. And then we also said that high urine output. High urine output's our favorite one to talk about because that's so easy to happen and so common. So, when you think about potassium, you should be thinking about muscular abnormalities. So then stop and think about, we already said that the big ones down here, the heart, right? The heart's a muscle. If you have a low or high potassium, it doesn't matter. It's going to destabilize the electrical activity in your heart. You got that thing that you see on TV all the time, the little hump and the line and the big hump. It's going to make that abnormal. And some of those abnormalities can be like immediately lethal. So if there's only one electrolyte you could check on your patient every day, it should be their potassium. And I think I put on the normal is 3.5 to 5. on an earlier slide. So, again, anything that increases your urine output can make it fall off. You have, if you have a low potassium, like your gut muscles won't work very well, so the patients may have constipation. They may get what's called a paralytic ileus, where the peristalsis just stops and food doesn't move through. They may be telling you they have cramps or muscle weakness. The telltale thing is the most scary thing is watching their heart. If a person has a dysrhythmia, their pulse is going to feel abnormal. So when you feel your pulse, that bump, it's very steady, it's very rhythmic, right? And that's because that interval in between that bump and bump is how long it takes the heart to fill up and to contract. So if there's something wrong in that electrical activity, your pulse isn't going to feel even. It's not going to feel even. So if you're taking care of a patient and you think they have a potassium imbalance, they need to either be on a cardiac monitor or you need to be frequently checking the quality of their pulse. Is it regular or not? It should be. If it's not rhythmic, if it varies, there's something that's an abnormal heartbeat. Y'all know what orthostatic hypotension is?
Mm-hmm.
And then causes of hyperkalemia. Okay, so if you have kidney failure and you can't pee, you're going to retain potassium. And there are some drugs that you'll learn about next semester in pharmacology that make you pee but don't. You hold on to potassium. They're called potassium-sparing diuretics. If you took those, that could also make you a little hyperkalemic. If you take in too much, and then if you're having cellular shifts because of acidosis or alkalosis. And so then when you get to the signs and symptoms, they're really going to be very similar. You're worried about muscular things. Remember, too, that all of your intercostal muscles, those are muscles that make you breathe. So people, when their potassiums get out of balance, can also breathe inappropriately. Not have good respiratory effort. Short, shallow little breaths rather than good deep. And then again, you see all those little stars by that electrical activity on the potassium. Okay. So if y'all want to run to the bathroom or saline into my vascular space, how do you think that's going to act? What do you think it's going to do? So if I am volume overloaded, that says maybe 0.7% of the fluid in my blood has sodium, compared to normal saline is 0.9. So is that not going to cause any fluid shifts anymore?
I didn't hear the first part.
It will, right? Because you've got a difference in your concentration now. So if I'm hypotonic, if I'm volume overloaded, that means that my sodium levels are low, and I put normal saline in, and it's higher, where do you think the water's going to move to? Into the vascular space. Remember I kept saying if you, in a person that's normally hydrated, it's not going anywhere? But if you are volume overloaded, your sodium is low, you're puffy and swollen and all that, and I put normal saline into your blood vessel space, it's going to pull water because it's a higher concentration than what you are. Does that make sense, y'all? Okay. And then the same thing is true if you're dehydrated. And my sodium is 152, and the normal is 145. Say my sodium is 152, and that makes me maybe 0.95% in my blood volume. If I put in normal saline, what is that going to do? It's a lower concentration, isn't it? Right, it's a lower concentration than what I currently am, so it's going to tend to push water out. So the moral of that story is you can pretty much use normal saline for almost every kind of fluid imbalance, and when you use normal saline, the correction that it's going to make in the fluid imbalance is going to be slow and steady. So it's good to use normal saline, particularly in people who might be at high risk for having complications of fluid imbalance. That would be the very old, the very young, people who have kidney failure or heart failure or liver failure already. So it's a given, really, in all of these scenarios that I've given you, that you can give your patient normal saline. and it's gonna cause the correction of the fluid imbalance to happen more slowly, a nice, slow, healthy pace. You know, if it's a 25-year-old that, you know, is stuck on a fishing boat in the Gulf for 3 days without anything to eat, they have a good heart and kidneys and all that, you can probably go ahead and give them hypotonic or hypertonic, and because they're young and healthy and have good organs, it won't matter. So if y'all would just kind of, y'all work through those, and I'll walk around and see if you're getting it, and if